what happens is we don't just see an improvement in the labs when we do these interventions. We see how an improvement in how the patient feels, like how she shows up in the world. They go from seeing in shades of gray to Technicolor. It's that being at home in your body versus, gosh, I'm just powering through.
We have so many options now, which is so amazing. And we're so fortunate, at least this generation, to at least have more information and know that we can. And hopefully for the future generations, there'll be even more clarity. All right. Well, it's a real pleasure to have Dr. Anna Cabeca, one of my favorites on the show again for the second time. Thank you. Welcome.
Oh, it's so good to be here with you. I'm going to pretend we're having tea in London, like when we first met.
That was like, it to me, it felt so right when you just connect with somebody and you feel like you've known them forever. So I'm so happy we crossed paths.
Me too. Yes.
And here we are again recording, and we talked about DHEA and libido and vaginal health, all this stuff when our last episode. And I'll have that episode linked in the show notes. And this time, I want to get your opinion on hormone testing, mammograms, vaginal progesterone, HRT, all these kinds of things. HRT when you have breast cancer. I'm not sure we can cover it all. So we're going to just try our best to squeeze everything in. But some of our episodes, some people have an agenda and they throw these things out, and then you just get a little confused, not really sure. So I really appreciate your more unbiased opinion on some of these things. And you're a practicing medical doctor, so you see patients all the time, and you're not just sort of researching stuff and here you go. So I really appreciate being able to pick your brain at this time. Okay.
I'm happy to help. I'm happy to help and share this information, because the more people know, the more people can speak up for themselves and advocate for themselves. Because I see patients in clinic, like even, for example, yesterday, and Zora, we may go off on some tangents, but even in clinic yesterday, I had a client who came to see me. She's now 50 years old, but she had a hysterectomy at age 35, then went 6 months to a year without ever being given hormones, and she was going crazy.
Oh my goodness.
And it's like at third, it's just such a mistake. Mistakes that are being made in medicine, not to address the underlying hormonal issues prior to surgery, let alone at time of surgery. We know there's hormone disruption. For example, hysterectomy, removing the ovaries, we know there's hormone disruption. So you've got to give that back. And things like that are still occurring. So
you would think it's malpractice to not help a woman with hormones, especially at that young age, post hysterectomy, and she's thrown into medical menopause and not knowing what's going on or why or what's happening. I can imagine. So I hope this changes. It's crazy to think that still happens.
I would say in today's day and age, now she had her hysterectomy many years ago, but in today's day and age, I would consider it malpractice too, and misinformation. And also the issue nowadays that, okay, we'll give you estrogen after we do this. Well, first of all, do we really need to do this surgery? Let's address the underlying root causes. And okay, we'll give you estrogen after, but because you don't have a uterus, you don't need progesterone. And that's a mistake too. You absolutely need progesterone. Our ovaries are huge producers of progesterone, and we need it for brain and other benefits to our body as we age. I will die taking my progesterone. I'm telling you, like into my 80s, 90s, and beyond, however many years God gives me. But I think it's this understanding the science and the utilization of these hormones, and also some of the misinformation that's been passed on over the years to really eliminate that. So I love that we're having this conversation today.
So actually, we're going to jump ahead of the first question, since we mentioned progesterone. Let's talk. I mean, we love this hormone. It's one of our best friends until she leaves. And then we're kind of stuck with a lot of issues. But I would like to fast track to, there was a menopausal doctor I interviewed, and she talked about some interesting studies that she found, albeit small. So she never made any conclusions or anything, but it just made her think. And she's thinking about it and trying to figure out which way to take her patients, because she's a practicing doctor as well. So she said that these two studies showed that one was given menopausal women given estrogen, and estrogen was dilating the blood vessels, great, fabulous, and blood flow. And then once they were given oral progesterone, I think it was 100 or maybe 200 milligrams, then those blood vessels contracted again. And so that's maybe not necessarily such a good thing, maybe not. And then the second study replicated the same thing, but instead gave vaginal progesterone cream. And they found that the arteries remained open and great blood flow and all that. So I asked her for the study and she said she was going to get it to me. I never got it. I tried to search for it, can't find it, but I'm wondering if you heard about these studies, if you know anything about oral progesterone versus the vaginal progesterone.
Yeah, so this is the difference. So I'm not familiar with those two studies. So Zora, definitely send them to me when you get them. But I'm not familiar with those two studies. But what we know is estrogen, oral estrogen can promote angiogenesis, and that is healthy blood vessels, blood supply. Until a certain point, oral estrogens also increase pro-inflammatory markers, such as your HSCRP or cardiac C-reactive protein. And so we have to be very cautious. So typically post-menopause, I don't give oral estrogen, I convert to transdermal estrogens. And that's really critical for longevity, quality of life, and health in general. So we'll go to transdermal routes. The progesterone, now it's good that she did, the research was on 100 to 200 milligrams, and that is typically a bioidentical progesterone doses versus Provera, which is a synthetic progestin, which is 10 milligrams orally. So I love oral progesterone to help us sleep. So for example, if we give someone 100 milligrams of oral progesterone, 90% of that gets metabolized into other derivatives, such as like allopregnanolone or GABA derivatives. So that helps us sleep, that helps us rest in most cases. And 10% really utilized as progesterone into our system. So that's a significant difference. So the benefits of oral progesterone are to help us sleep. However, some people feel hyper on oral progesterone. And what's happening? We make our cortisol from progesterone. So what's happening there? So we're pushing the cortisol curve, essentially. We're pushing the gas pedal on our cortisol, our stress hormone. And so then progesterone, okay, I've got more progesterone. I'm going to push it towards cortisol, and now I'm awake and my blood sugar is elevated and I'm a little anxious now. What's happening? And that's the case that, okay, we're not going to use oral progesterone in that individual for sure. Or if we need to, we could use it in the morning and help support cortisol throughout the day. So that's the refinement. There's a refining of a bioidentical hormone usage. I love topical progesterone, and I combine it with pregnenolone. So progesterone and pregnenolone together transdermally is very, very well absorbed. And I use micronized progesterone. So it's very, very well absorbed, and it's in a base that helps it drive into the tissues, which makes a difference. Not all topicals are created equal, but I've been doing this now for many, many decades. So it really refined that combination so that we can see progesterone transdermally or transvaginally well absorbed. Now, the issue is when it's not being well absorbed transdermally through the skin, we have to think, okay, there's a problem with this large organ of our body, the skin. So it's usually a gut issue. There's usually a gut dysbiosis or something else going on. So if you're using a topical cream and we know it's a good quality a topical progesterone, and you're not feeling anything, or we're not seeing any results in urine studies, for instance, then you're not absorbing. There's a gut issue. So I always have to treat your hormones, I have to treat your gut. It's critical to make sure that we get this right. And so that's one big thing. And then the transvaginal has been well studied. Transvaginal progesterone has been well studied for fertility, as well as in menopause for opposing estrogen on the uterine lining, because we can't use unopposed estrogen with a uterus. We need to balance it with progesterone. And whenever I talk hormones, I'm only talking or prescribing bioidentical hormones with rare exception. And so vaginal progesterone was studied at 50 milligrams in fertility for IVF situations. And at 50 milligrams, vaginal progesterone is well absorbed vaginally and is great to support the endometrium, especially for implantation, for fertility. So when we're looking for fertility, it's typically 50 milligrams vaginally that we'll use. And again, very well reabsorbed. We can see that in the bloodstream as well as urine and salivary testing. Topically, I use 20 milligrams of progesterone, which essentially, well absorbed, is equivalent to 200 milligrams oral progesterone. So that's the difference.
So yeah, I remember in our last conversation, you really opened my eyes to vaginal DHEA because we were talking about vaginal health, and you said the tissue, the difference between the so giving a vaginal DHEA versus taking it as a supplement is that or versus even the estriol that we can put in as vaginally, the DHEA vaginal that was actually being so much more absorbed and getting down to the other layers of the vaginal wall that say estriol couldn't do. And that was amazing. So then it made me think when I heard this other we had this conversation about vaginal progesterone. I said, okay, wow, it seems as though the vagina is like, this is pretty absorbable. It's absorbing things quite well, maybe not everything, but in terms of it would maybe make sense that the progesterone is the uptake. And you said for the uterine lining, and I've read that as well, that, wow, okay, well, it makes more sense. It's closer to the uterus. So perhaps it's better absorbed and it's better for those things. But how does it compare if you're looking for sleep and some of the other benefits of progesterone, if you're going to put the cream on your arms versus vaginally? Do you get the same benefits?
Well, many people do. Many people do get the same benefits, calming, deeper, restorative sleep. But if we're still not getting there, that's where we've got to address other issues too. Well, I mean, in general, we have to address the other issues. Blue light exposure at bedtime, EMFs at bedtime, the cold, dark environment that we need to have at bedtime so that we get deep restorative sleep. And are we making enough melatonin? So progesterone helps support whether we're doing it vaginally, transdermally, or orally. It helps support tryptophan. So it decreases the degradation or the breakdown of tryptophan. So then we can metabolize tryptophan into serotonin and then into melatonin, which is what we need for sleep. And this is so important because what are the perimenopausal symptoms that people complain with? Anxiety, so low serotonin, and difficulty sleeping, not feeling rested, decreased energy, so not enough melatonin. So if we start at the top, and that's why estrogen is one of the last hormones I replace, because I want to replace the hormones that are declining naturally as our life cycle in our life cycle. So to support our hormones early on, it's DHEA, it's progesterone, then testosterone and estrogen.
Yeah, I always advise that approach too when a woman just gets started, because you can see there's downstream you may have the benefits, and perhaps with the testing and how you're feeling, you go, well, actually, I don't really need estrogen yet, because everything's being helped maybe with even pregnenolone, a precursor for so many of these other hormones. So I'm happy to hear you say that, because that's the way I was taught with Dr. David Rosensweet through his Institute of Bioidentical Medicine. And I thought, oh, that makes sense. And I like that. And sort of an approach where one can see how you are first and then add, because if you throw everything in together at the same time, yeah, you may not know which lever to pull and push if they're all mixed together in the beginning, right?
Right. That's absolutely true. So it's nice to do stepwise approach too. And again, the lifespan of our individual. And I want to go back to what you said about vaginal DHEA. That's critically important. But I'm big on the double V. So vulva vaginal area. Do not forget the vulva, clitoris to anus, like that entire area, geography of our body, the most important real estate of our body is hormonally affected too. And addressing that with the topical DHEA, for instance, with other key ingredients can really help with blood flow, circulation, vitality, sensation, orgasm, all of that. The vulvovaginal area, very well innervated, very vascular, is also important. When we're just talking, a lot of times now in the news, you hear vaginal estrogen. It's just not working on the clitoris or the vulvar area or the anal tissue as well. And you want to keep that healthy. So like the opening to our womb, let's say, the vulvovaginal area and those sensory zones need hormones just like the rest of us, and for life, so that we don't struggle with the loss of pleasure, loss of sensation, decrease in orgasm, things like that, as well as incontinence, vaginal dysbiosis. When we talk about gut dysbiosis, but vaginal dysbiosis is a huge issue, and it causes quality of life issues and diseases as we age if we're not addressing that too.
It's okay. Sure, it's a whole other episode on vaginal dysbiosis. Giving me ideas. I'm a little confused though sometimes when I hear that, say, the vaginal area is actually really well. People can really absorb very well because sometimes,
Absolutely.
yeah, if you're not absorbing it through your arms, then kind of okay, let's try the vagina. But then when we think about doctors talking about estrogen, and if you have breast cancer, the ones who are afraid to treat a woman in breast cancer, they'll say, oh, well, you can take it vaginally. That's local. That's not systemic. But I'm wondering, is it really not systemic? Because it sounds like, well, if it's absorbing pretty well, is it honestly really just stay there, or can it go systemically?
So can understand through studies looking at salivary testing and urinary testing that there is an absorption. It's typically lymphatic glandular absorption and also microvascular. Again, we think of the vagina, the mucosal lining of the vagina is like the mucosa within our mouth. So it absorbs really well. It's good vascular. You don't have a thick epidermal barrier, but you get that good absorption. So there's a lymphatic component, not well studied, but yet in practice, in labs that have been studying this, whether it's transdermal versus vaginal use of hormones and looking at salivary testing and urinary testing, there's no question that it's absorbed through the system. So maybe microvascular absorption, but a lymphatic absorption has to be a key component of that.
So yeah, well then I guess maybe also people are bio-individual. Some people are going to absorb it more through the vaginal walls. Other people maybe other areas of the body. But if anybody was concerned, I would say, well, go test, go see. In the end,
Go see. And this was studied in a presentation that, gosh, way back in 2006. A presenter was looking at absorption based on where on your body you're applying the hormones and noting that, okay, so from behind the knees to the lower abdomen to around the neck, what is the salivary result? And of course, there's more concentration in the saliva the closer to the salivary glands you get. So that makes sense. That makes sense. So you have to think about it. But again, we're still getting a full body of circulation, a full body benefit. The other thing is with hormone creams, like you said, okay, put it on the inner arm or the shoulder or wherever, the inner underarm or wherever, or lower abdomen. I'm like, gosh, hormones are great, are great for skin health and for glowing, radiant skin. So I'm like, okay, progesterone, pregnenolone up here, also DHA up here, face, neck, and décolletage area. Keep that nice and radiant, right? And the same thing with topical estrogens. Can use that on different parts of the body to get the benefit. Always also rotate like primarily in the vulvovaginal area.
yeah, I do the same. I'm just putting,
Yeah.
a little residue back on my face, going, okay, this has got to be good. I mean, there is some studies showing how that it is quite beneficial. So we'll see. But I wanted to get into testing now because that is another confusing topic for women going through menopause. And some of their doctors want them to test and they want the data. Others say it's totally useless. Some doctors like to see hormone levels in their blood test. Others like to see the metabolites in a urine test. So what are your thoughts on hormone testing? And perhaps are there other tests that matter other than our sex hormones in this perimenopause and post-menopause?
I love this topic. I've often lectured on it, and I teach a whole module in my Magic Menopause program specifically about understanding your testing and the different ways we can test. And for blood versus blood serum testing and urinary testing, what are we looking for if we're doing salivary testing and other functional tests that we can look at? We can go really deep in this this topic, but when we think of hormone testing in general, in perimenopause, we are in a regular menstrual cycle. We have to test not on birth control pills. First of all, need to be 2 to 3 months off birth control pills. Secondly, you want to look at FSH, LH, and estradiol estradiol on cycle day 2, and even an AMH, anti-Mullerian hormone, if we're really looking at ovarian reserve too for fertility reasons as well. But FSH, LH, and estradiol on day 2, progesterone day 21 in the blood. So those are some of the key things. I also look at pregnenolone levels, melatonin levels. I look at DHEA sulfate. I look at testosterone free and total testosterone. I look at total estrogens and estradiol. So really want to understand what's happening with your hormones. And that's just when we're specifically looking at hormones. In the perimenopause and menopause, FSH and LH start to increase as ovarian reserve declines, as ovarian function declines. So we start to see that a nice low FSH and LH, they have 4 and 3, respectively, go to 15 and 11. And we're like, okay, there's diminished ovarian reserve. You may or may not get pregnant. But when it's 30 to 40 for your FSH, we know there's resistance on cycle day 2, because we're going to get peak levels at day 11 to 13. And so it really matters when we test and consistently retest at the same time, the same day of our cycle. And postmenopausally, now not so such an issue if we're more than a year past our last period. We want to just look at, I say, same time of day without exercise. If we're getting labs drawn at 9 a.m., look at your before exercise, look at FSH, estradiol, testosterone, progesterone, and those key labs. And FSH, people think, oh, well, we know you're postmenopausal, so why look at the FSH? So I dug deep into the research with this because I was seeing a pattern in certain patients. And so I dug deep into FSH. I was like, okay, FSH postmenopausally, there's got to be something here with bone loss. And the higher your FSH, the more bone loss turnover you have. And the higher FSH, the more brown fat, metabolically active brown fat, converts to metabolically inactive white fat. Okay. So that means, okay, weight gain without doing anything different, waist gain without doing anything different, stuff like that. So I want to, when I'm implementing lifestyle, and there's certain lifestyle nutrients, adaptogens we can definitely use to help lower the FSH and LH. I do it all the time for pregnancy and also postmenopause. But then with hormone therapy, are we on enough, especially if we're using transdermal or transvaginal? Are we driving that FSH and LH? I like to see it around below 40, certainly, but closer to 30. And at least really driving that FSH and LH down. We want it below those numbers, so that I know I'm maintaining bone, I'm getting these therapeutic, and if we're not, then we're not therapeutic, and we have to look at other things as well. So it's important to test, not guess, and what gets measured gets managed, and it's a complex picture. And again, this has been years of my own research and clinical work, but this has to be part of our management of postmenopausal women.
Yes. It's interesting you said about the bone loss accelerated when your FSH is going up and up and up. And Dr. Lindsay Berkson, I'm not sure if you've heard
I know
of her.
her, yes.
I remember
Brilliant.
interviewing her, and she was talking about the brain being protected when FSH is lower. And I think she said, if I remember correctly, you want to get under 20 for brain protection, and ideally like 5. She's like 5 herself, something crazy, and she's done it.
Yeah,
and
yeah.
So there's studies there. So it'd be interesting. I would love to have these studies too. What is the number generally? Is it the 30, under 30 for bone protection?
That's a good question. I'm not 100% sure, but what I look for, and if we go to the reproductive ages, then we're looking at under 10 for sure. We're looking at under 10 for an FSH. So that would be a goal. Certainly if we have osteoporosis or we have bone turnover, we need to look at the bone turnover markers. Those are the N-telopeptides, and any lab can do it. Every physician listening or every client can even self-order these labs, but you want to look at urinary telopeptides, and that's a marker of bone turnover. So you want to get those numbers nice and low. So I had a client who is 47 and she had long COVID, and as a result of 5 COVID injections, she had long COVID and also it was pushed into menopause. And so I did a bone density a scan on her, and I think she's got, how old is she now? She's 42 or something, maybe 40 when she came to see me. So young. And her FSH was really, really high. Did a bone density scan on her, and she's osteoporotic. So we really looked at her N-telepeptides, and her number was 115. Man, I like to see that number at 15. So her number was 115. And so really working aggressively to get those numbers down there's a nutritional component to osteoporosis and bone loss, and there's a hormonal component. You have to do both together.
Interesting. So if somebody is postmenopausal, let's say, and her FSH is 40, and she hears this and she's, oh, I want to protect my brain. I want to get under 20 or under. Could you change that with just the diet and lifestyle alone, or do you bring in hormones at that point?
It depends, but definitely it's about ovarian function and adrenal function and inflammation within the body, as well as cortisol and insulin sensitivity. So for me, I wrap that into what I call my keto green method or keto green approach. So absolutely, diet, nutrition, and lifestyle is critical. It is critical piece. It is 90% of it. It is, and I was going to say 90% because I'm a physician and I still have an ego and I want to claim 10% you need me for this, right? But it is it really is. Nutrition and lifestyle is key. And that's the food we eat, the quality food, making sure that it's organic, free range, no pesticides, all that important stuff, because all of that's hormone disruptors. We're eating we're eating meat that's been treated, or fish that's been treated with antibiotics. We're absorbing that, and that's killing off a defense mechanism. So it's really a holistic approach that we have to take in working with this. So the nutritional changes, when we eat, what we eat, the mindset with which we eat, the activities we do during the day, the blue light exposure we have during the day, et cetera. All of that has to play into it. I wish it was as easy as let's just drive down the hormones let's drive down these numbers with hormones, or let's just keep increasing your hormones until you feel better, which is a mistake. It's a mistake, because then you're really suppressing, honestly, my clinical experience that I say this because we have limited research, but it's my clinical experience that when you have higher dose hormones, you're suppressing the HPA axis. We know this to be true based on scientific studies and case studies published on men who have been given high dose testosterone, and then it stops. Like they're on testosterone injections, testosterone pellets, and all of a sudden they can't go in. Financial reasons, personal reasons, whatever the situation may be, hospitalized for something, and they go into deep depression and have an significantly increased risk of testosterone. We also know physically it causes testicular shrinkage, right? Yeah. So the testicles shrink, and the guys are like, well, I feel better, so I don't really care about my testicles, until you don't. But what's that telling you? You've now suppressed. It's no better than birth control pill, right? It's no better than birth control pill. So we have to think of this. This is very intuitive and observational in so many ways, but yet we're seeing these scientific reports looking at this. Now, not so much in women, because how are you measuring the ovaries after high dose testosterone? I can tell you that people feel physiologically better when we optimize hormone levels, not over, not under, but optimal for that individual in the right optimal conditions. Because if you think, okay, I'm big, like Mother Nature has it all the time, right? You can't beat Mother Nature. So what's Mother Nature telling us? Well, within this body, which is the cathedral of our spirit, it's complex, right? It's an energetic body, a spiritual body, an emotional body, and a physical body. It's all combined. We look at, okay, what are the effects? Where can we optimize every aspect of our life to improve the quality of the energetic body within the physical body, as well as the physical body, for the longest duration of time? Yeah, there's no straight formula for that, but it's the bio-individuality that we have. But the good news is our body's constantly regenerating cells, so we can always be healthier tomorrow than we are today.
Yeah, I love your approach. And it is, I wish all doctors were like this, because And even the ones I interview who are thinking just like you, but sometimes we get so much into the hormone conversation, we forget to say, you can't out hormone a bad diet and lifestyle. Hormones are
Right.
great. They're there to support, but like a supplement, but we need to do all the hard work anyways, whether or not you're on hormones. And I just can't stress that enough. And I appreciate you saying that too, because it's really important to remind us we can't just pop a pill or put on a cream and then expect life to be all rosy again without ignoring all the other things. And not that we have to be 100%. We don't live in a cave or always eat at home all the time. People go out and they with other people, and you are getting exposed to free radicals from every direction, one way or another. I think personally, it's just about having more good days than bad, I guess. And I don't know what that number is. Some people say 80-20, somebody 90-10, and then maybe some people can get away with 60-40. I don't know, because their biology is allowing them to do that. And they're going to, look at me. And well, you're different.
Right. Right. Yeah.
Right.
And the exposures are different. And then we look at these aspects. And I think about a client that I had in my practice recently, and she is 55 years old, and she had a hysterectomy due to heavy bleeding at age 50. And her looking at her labs from back then, her FSH and LH and estradiol levels they were optimal. She was nowhere near menopause at that point. She was having dysfunctional bleeding from that aspect. So she was progesterone deficient. So the intervention at that time would have been to support her adrenals, support her detox pathway, support her progesterone levels, supplement with progesterone levels, with progesterone. And so that probably maybe would have avoided the hysterectomy. But then at the time of hysterectomy, she was given estrogen only and still not addressed with progesterone. So then we're adding in progesterone to help her with the symptoms of low and insufficient progesterone, which she had, which was probably one of the reasons that caused the problems to begin with. And also symptomatic fibroids, which is an indicator of toxicity and impaired detoxification. So we still have to, with or without the uterus, we still have to address those issues that cause the need for the hysterectomy to begin with as well. So it's complex. I wish it was as easy as let's just give hormones, but you've got to address the detox pathways. You have to address the lifestyle. You have to address the mindset. You have to improve on the most powerful hormone of our body, oxytocin, on a daily basis. We have to do those things in addition, especially if we're implementing other hormonal therapies.
I don't want to forget, you mentioned this test for bone turnover. It was anti-telopeptide, or
No,
how do you
N-telopeptides.
N-telopeptide.
N-telopeptide. So
Okay.
NTX is sometimes abbreviated NTX, but Quest, LabCorp, and they can do a 24-hour urine, which I usually like for a baseline, or morning urine bone turnover. And it's just a lovely test to know whether you're optimizing therapy, you're getting results versus waiting 2 years for another bone density scan to see, oh, well, no, we really haven't moved the needle, or yes, or yes, we
Exactly.
have.
Yeah. And
In 3 months, you can see a difference.
in 3 months. Wow. Okay. This is
Every
so
3 months, you
fabulous.
can
I
do
learned
that.
something new here. Do you know about the REMS scan? REMS?
Mm-mm.
Oh,
No, what is
okay.
that?
I'll have to connect you. Evidently, this is next level DEXA. DEXA is kind of the old school. Now we have to test not only bone density, but we can test bone strength. And this is a Dr. Doug Lucas. Have you heard? He's the bone doctor. He's really into it. Gary Rhodes, I did a great podcast with him. I'll share them with you because actually it's quite interesting, and because the data that they get may show you have osteopenia, but you may have osteopenia, but if your bones are very strong, you're at very low risk for a fracture. And I was like, oh, I didn't know you could be osteopenia and still have strong bones, but you evidently can. And then the scan comes with a lot of information. Okay, you still check all your vitamin levels, make sure you're on the right supplements, make sure you do walk outside, get impact. You can use a weighted vest, et cetera, nutrition, things that we need to do, rather than, okay, great, continue with your calcium supplement and just walk. Like, they're a little bit next level in terms of this kind of scanning, and they're trying to it's for technology from Italy, and now it's coming out more and more in the US and the UK. But I think it sounds awesome, and I'd love to get your opinion on it. So I'm going to send them your way, and you let me know.
Yeah, absolutely. And I think that's an important issue because it's absolutely correct. 'Cause what we found with the bisphosphonates, use of bisphosphonates over the years, they might improve bone density, but now it's more fractionable, right? It's hard, brittle bone versus strong, flexible bone. And
Yes.
so I love that. I love that there's a study to be able to look at this now because that is exactly the point is you want strong, flexible bone, be it metabolically active bone, and that's critical versus where people on bisphosphonates were getting multiple fractures. And
Insane.
so
Something that's
strong,
supposed
brittle bone. Yeah, I mean hard brittle bone. Yeah, we don't
Oh
want
yeah,
that
hard
at
brittle
all.
bones. Okay, yeah, it's not going the right way.
No.
The just going back to the testing a little bit, in terms of urine testing and metabolites, is this something that you look at with your patients?
Yes. Yeah, absolutely.
Okay. And do you have a preference, the 24-hour urine or the Dutch? Is there a difference for you?
There are several good labs that do urinary hormone metabolites and have been for years. In the US, we have Dutch Precision Laboratories Dutch test. So that's our Dutch test. We have Meridian Valley Labs. We have Genova. So there are several labs. I know there are a bunch more that I just can't think of right now, but there are multiple labs that do this.
That's the dried urine
I
test, just so people don't, they're
dry,
not, do you pee on a stick or you let it dry and then 24 hours later you send it in. So that's dried. Yeah.
The, that's yes, that dried urine test is the Dutch test. And I like that one. I've used different ones over a significant amount of time period. The HUMAP is another one. So
Mhm.
it's just what's your clinician good at interpreting. I like for patient, I'm also managing my own hormones. I'm also a patient. And so for me, the Dutch test makes it easier. I feel like clinically it correlates with what I'm seeing in the patient. I don't throw a lot of labs at a person at one time, typically, again, with rare exception, but over time. So initially, I get quick results with serum testing and looking at the HPA axis and thyroid function and other aspects of a good, healthy metabolism and glucose sensitivity, insulin sensitivity, things like that. So I look at those factors. And then I follow up if whether I've started hormonal therapy or not. I also want to look at what your body's doing with your hormones. So in 3 to 6 months, I recommend a Dutch test, complete test, or one of the other urinary metabolite testing and look at how your body's detoxifying those hormones. And that includes the 2,4,16 hydroxyestrogen pathways. It's really critical to understand that and look at those pathways and also to support and reduce the risk of breast cancer, or is there other detox issues or immune issues? Because our genetics, our epigenetics, have a role in our detoxification pathways, as well as our microbiomes. We want to look at this in context. And it is nuanced. It is a challenge. I talk about it and give a module on it in my Magic Menopause course too. It's over an hour long module, and that just gives you the basics, right? It is complex, but the more we do it, the more we understand. And for me, it's a critical picture of optimizing our quality of life and our detox pathways, whether we're on hormones or not.
I agree. I'm leaning towards that. But you do see a lot of these doctors are big influencers, and they're following very often the guidelines of the Menopause Society. And they're really, I would say, if a doctor's prescribing Dutch, run as fast as you can. And I'm like, what are you talking about? I guess if they're not trained or if they're not used to it, maybe they're not familiar with it. For them, okay, they have other ways to look at it. I don't know. Why are they so not into it?
Um, they're unfamiliar. Yeah, they're unfamiliar. We haven't been trained that way, but when we are trained, even my youngest daughter's in chemistry and she's studying the Krebs cycle. And where do we see the metabolites of the Krebs cycle? In the urine. The urine is much more than ammonia and water, right? It is much more. It is, and why we say if you're taking birth control pills, why are there hormones, synthetic hormones in our water supply? It's because we're peeing them out. So it's ignorant to not look at the full picture of what your body's doing with your hormones in this day and age.
Thank you. Thank you. I keep getting surprised. I'm like, why do people do this?
Well, the other piece too is that hormones are more than chemical messengers, they're energetic messengers. So
Hmm.
we really haven't developed excellent technology and really understanding the energetic complexity of hormones or being able to measure hormones energetically. I think that is part of the diagnostic tools of the future. And I know there's some preliminary development in that area, but that's complex. Hormones are complex. They fluctuate over time. Getting a full picture. When we look at the blood, we're looking at that one instance in time. That's why we have to make it as reproducible as possible as far as the time, the condition, the stress level, et cetera, when we do our lab testing. So we need to look at that in context over time and take it. I would say what gets measured gets managed, but treat the patient, not the labs. I mean, there is that sense like we are complex, so we want to look at the full picture. And this is where the art of medicine comes into play. And anyone listening from our discussion right now will be like, oh my God, it's so complex. But you start with one baby step at a time, one baby step at a time. And honestly, I've been doing this 30 years. I'm still learning.
I know I have so much respect for you, and I'm just so grateful you're here with us and explaining some of these things. And I'm wondering then if yeah, I'm really glad you talk about testing so much more than estrogen, progesterone, and testosterone, because that's what a woman typically thinks. And even the woman, let's say, who's asymptomatic, okay, in terms of treating the patient, okay, maybe she's not feeling anything, but that doesn't mean nothing's happening under the hood. So it's so wise to look at her bones and her breasts and her vaginal health. She may not be thinking about that or making that connection that her brain fog has something to do with the loss of the hormones, or maybe some other hormone, weight gain, maybe it's the thyroid, maybe it's something else. And so taking a little deeper dive and looking at other testing is so crucial, I believe. And it's kind of just getting your whole checkup. Like you check up your car and get a diagnostic on how that's running. Why not do it every year for yourself, and not wait until you're sick? But even you're not feeling bad, the first thing I do is just go find a menopause doctor to help you through this, because obviously you're going through this transition and things need to be taken into context. So I'm glad that you mentioned a lot of other testing, which is really cool. So let's talk about mammograms if we have a little bit more time, and we'll try to not go too far. Some doctors are for it, some are against it. What kind of breast screening do you ask your patients to do?
So I think like when we think of what types of breast screening is available to the patient right now, we have mammograms, we have ultrasounds, we have MRIs. Insurance won't cover without diagnosis codes and doing the prior to. We have optional thermography testing, and there's different types of mammograms like QT mammograms. There's the imaging of mammogram available in a few cities where you're laying down and your breasts are into vacuum as opposed to being compressed between two plates, essentially. And there's better ways, but the problem is we know that annual mammograms increase your risk, increase the incidence of breast cancer. So we don't want to do annual mammograms, but can they be helpful? And I'll tell you, I had a client yesterday, recently in my office, and she hasn't had a mammogram since prior to her hysterectomy a decade ago. And that's my first time seeing her. And prior to implants, breast implants. And so I was evaluating her, and I said, well, we're discussing hormonal therapy. I said, I need to get a baseline mammogram, and I'll tell you why. Again, I'm not pro radiation in any instance, but prepare you supplement wise for that radiation exposure. Secondly, it will tell me a couple things. It'll look and say, okay, we've got a safe baseline. And really, for standard medical care, I need that for peace of mind for a couple reasons. Even though I'm doing a breast exam, checking the axilla and supracervical lymph nodes and all of that stuff too. And that I also want to look for calcifications, because it can be benign calcifications, but also when we see calcifications in the breast tissues, I used to ignore them. Like for a decade of initial practice, I would see benign breast calcifications. But what that tells me is there's calcifications. That could be along vessel. If they're on the mammary vessels, they could be on cardiac vessels. They could be somewhere else in your body. We don't want you to be depositing calcium. And if you are, there's inflammation. So we've got to reduce that inflammation. So that'll tell me that too. So we can kind of look at two birds with one stone in that instance. And then it will prepare you well for, we want to try to do the non-compression type of mammogram study, so that especially with the implants, but with the radiation exposures, we're going to do high dose vitamin C before and after. We're going to do iodine therapy before and after. She has negative thyroid antibodies. So we'll do that to help mitigate some of the exposure to the radiation. And again, we want to evaluate this at one point. We have follow-up next year at some point too with thermogram. Mammogram will miss things, thermogram will miss things. And we'll see it in MRI, which I like, ultrasound I like because those are benign. MRI without contrast is not significantly harmful, is like less harmful or very benign. We understand ultrasound, very benign type of diagnostic study. So there's no radiation involved. And so we can look at those aspects also to see what's going on. But typically, unless you feel something, insurance doesn't cover for an ultrasound. And the same thing with MRI. If we don't see something on mammogram, it's really hard to push for that MRI. I like my clients to do full body MRIs because you never know what's brewing. If we're looking at a longevity, okay, what's your status now? Perfection? Are you perfection? Or is there some area that we need to see that we can't see in the blood, we can't see on our routine exam or screening? And what else is going on? So an MRI can show gallstones, can show brain tumors, can show breast implant rupture, can show other aspects. To do something like that, it is cash pay. I put it in my client recommendations and I try to get them to do that. There's companies that are set up to do full body MRIs that are looking at these images. So the Pronuvo scan is one of them.
Pronuva? I haven't heard of that one.
Pronuvo, Prenuvo.
Pronuva. And how does that work?
So it's full body MRI. It's cash pay.
Okay.
Yep.
Okay. So that's a specific type of MRI that looks at the whole body, not just at certain parts. I don't know. The gold's like the Rolls Royce of
Right.
MRIs.
Absolutely. Yes. I've done one 2 years in a row to evaluate a little bit of degenerative joint in my little aching shoulder. Okay, I've really got to up my collagen, decrease my inflammatory markers. A little bit formation of a gallstone, need to increase my liver and gallbladder enzymes. It's like little things like that. Other people have found tumors. Other people have found things that you're not going to see until they're problematic, pancreatic tumors, colon cancer, etc. So you don't want to wait for it to be a problem. So if that's part of, and I think it's somewhere between $1,500 and $2,000 to do it. So it is a huge expense, but in the long run, having a negative baseline is very, very life-saving.
Yeah.
And economical.
So after it's many interviews talking about mammograms, it seems that the people that I've been inviting in general, they mention that the mammograms, if it's the best thing about it is it's widely available and it's covered by insurance. So it's kind of, okay, better than nothing. And then you can offset some of the things with radiation hacks, like you said. And I've heard of high dose vitamin C, 2 to 4 grams, and then 100 to 200 milligrams of melatonin. It's a high dose, but you do that an hour before, and then 3 days after. You had another hack. What was your hack for radiation?
Iodine.
How
Same
much,
thing.
or does it depend on the person?
Well, you would say 12.5 milligrams. Typically, 12.5 milligrams daily, 3 days before and 3 days after.
Mm-hmm.
Again, that's a high dose. I mean, potentially, you can give as much as 50 milligrams iodine, but you want to be cautious. The other thing, when I fly, if I remember, I'll take my ivermectin, high dose vitamin C, take Mighty Maca, of course, every day, but before and after I fly, sometimes during the flight, and iodine too, because of the radiation exposure. And something I encourage my flight attendants and pilots to do as well.
Yeah, but then they're always, I mean, since they're traveling all the time, having high doses all the time, is that not a problem?
Well, 2 to 4 grams of vitamin C isn't that high. And the iodine, if you're flying all the time, you again want to look at your thyroid antibodies. But iodine, daily nutrient, you can just maintain a small daily amount, or iodine-rich foods, things like that can be improved upon. I hadn't heard about the high dose melatonin for radiation exposure. That's a new one to me.
Oh yeah, you can talk to Dr. Jen Simmons about that one. She's the one who
Okay.
gave me that one. That was it's so interesting how we can offset. Sometimes we just have to, like we feel okay, we'll make that choice and we want to make it with confidence and at least knowing that we can offset things. But in terms of the breast density, when you have dense breasts, as I understand, it's like finding a snowflake in a snowstorm with a mammogram that it cannot there's a high risk that you won't pick up some tumors. So then what would you recommend for somebody to do instead or in addition to?
Yeah, definitely. Can of course breast mammogram. Is there any area that feels suspicious? Then we order an ultrasound or questionable. If this dense tissue, we have to do the baseline mammogram, shows tissue. I still palpating something or feeling something inconsistent. Let's do ultrasound in these areas. Usually I like to do the bilateral areas in both breast. And then, so you have that, you have breast MRI, you have thermogram also looks at what a thermogram looks at. And again, there's the thermogram also depends on the expertise of the thermographer. So you want to go, I mean, that really is a key point. But thermograms been around for a long time. And what that shows us is their inflammation. Because when there's a metastasis, it has recruited blood supply, blood flow, and that shows up as increased heat. And so when you see these hot spots, we work nutritionally to support your body elimination of those hot spots. The other thing too with breast imaging, again, looking at your estrogen detoxification pathways and supporting those. So using estrogen detox support. So you have DIM, you have SGS, sulforaphanes, you have chaste tree berry, which is excellent, evening primrose oil, so GLA, gamma linolenic acid, and iodine can also help support breast tissue and decrease breast cyst or inflammation in the breast. So those are, and then castor oil packs. I mean, we can support, if you've got dense breast tissue, is it pathological dense breast tissue or is it healthy breast dense tissue? But if it's fibrocystic in nature, then we want to look at that and say, okay, how can we decrease that fibrocystic nature? Because there's a little inflammation going on there. So what can we do to decrease that, improve circulation, decrease the fire of that, so to speak?
What about calcium D-glucarate
Calcium D-glucarate,
and
excellent.
acetyl?
Again, and then you want to look if you're using, sometimes I've learned from an expert in urinary hormone metabolites and estrogen detoxification that calcium D-glucarate works for a majority, but there's a certain percentage that is missing a gene, and I forget which one, but that it doesn't work for. So again, what are your results if this is working? And are we depleting your estrogen too much with calcium D-glucarate? What's happening? What's the consequences of that too? So again, what gets measured gets managed.
Exactly. There's also indole 3 carbinol. Have you
Yes.
and NAC and
I
N-acetylcysteine?
usually use DIM instead of indole 3 carbinol. So I
Why?
typically use DIM, better results, more clinical benefit to it. And yeah, so
Hmm.
I prefer DIM over I3C.
Hmm.
And then what else do we use? I know you had a couple other you were mentioning.
NAC and
Oh,
acetylcysteine.
N-acetylcysteine to help support glutathione production is
Yeah.
an excellent supplement. It really supports your immune system and detox pathways in general. So again, knowing which pathways, especially if you have a higher 4-hydroxyestrogen level, and that was the other thing with this client. It was my first time seeing her, but she'd had a Dutch test prior, and she had high 4 and high 16 hydroxyestrogen levels and lower 2 methoxy. So that's a pathologic pathway. I need to see what's happening in her breast as well as the rest of her body. And also, we've intervening with hormone therapy, or she'd been on some hormone therapy. So, optimizing hormone therapy, I need to clear those pathways. So, here you want to use glutathione or NAC, you want to use DIM, calcium D-glucarate, and just look and see what flaxseed, evening primrose oil, you know, you want to support these pathways and support methylation pathways too. So it runs down the 2-hydroxy or methoxy estrogen pathway. What happens is we don't just see an improvement in the labs when we do these interventions. We see how an improvement in how the patient feels, like how she shows up in the world. And like they go from seeing in shades of gray to Technicolor. It's that being at home in your body versus, gosh, I'm just powering through.
Yeah.
Yeah.
So we have so many options now, which is so amazing. And we're so fortunate, at least this generation, to at least have more information and know that we can. And hopefully for the future generations, there'll be even more clarity. But I want to go back quickly to the thermogram because that one is, as I understand, is sort of an add-on because it isn't quite the screening tool and you're done, right? Or would you just say that's good enough for me?
So typically the way I recommend it clinically is if you're doing a mammogram every few years, in between do a thermogram. If there's any issues, we want to keep addressing it and optimizing the thermogram.
So would a woman who's got dense breasts, who doesn't want to be doing the radiation, and I've got some extra cash, would she be going for the MRI with contrast or the ultrasound or
I would say first step would be thermogram.
oh, thermogram, really?
Mhm.
Okay.
Yeah.
Interesting.
Yeah, because see if we can move the needle, can make any improvements versus an MRI, but it depends. So do we want an MRI a 30-year-old's breast? Not particularly. What else is going on? When do we start with this? Although again, a full body baseline MRI is good for a number of things.
Yeah.
So it comes to the clinical exam, right? What are we looking for? What are we suspicious about? What do we want to be proactive about? And then address those areas.
And it probably depends on the risk. Like dense breast is a risk factor. Having a history of your family member have breast cancer, then you're more at a risk. And I think then it seems to be you need to get a little bit more fine tuning your screening rather than, okay, I'm just going to not do anything else but the thermogram. And maybe that's if you're just screening and you have no other risk factors, maybe that would be fine.
Yeah, well, and for example, say I have a client who had a history of breast malignancy, a breast cancer in one breast, and that was removed, treated, chemotherapy, radiation therapy. The number one risk for breast cancer is a prior history of breast cancer. So now what am I doing for that individual? I'm optimizing her. Again, other issues, even more important than hormones, is insulin sensitivity, getting her hemoglobin A1C down, getting her adrenal support and immune system high functioning, improving circulation, decreasing inflammation. Those are, and empowering her detoxification pathways. Keep looking for, well, what caused the breast cancer to begin with? Because it's very rare to be a genetic component alone. So we look at those issues, address those issues. Now screening, what's our screening? For her, ultrasound and MRI to decrease mammographic radiation exposure, as well as consider periodically doing a thermogram and following those results.
So you would still
It's
say,
hard. I will say it's hard to follow thermogram results. It can be very complex and it's challenging. When I had my practice in Georgia, I had a thermographer come up every 3 months to do a breast imaging. It was cash pay, $100 each time she did thermogram, kept the prices reasonable. So the prices vary for thermography, but she did breast and thyroid thermography because they're the two critical areas of importance. And so we're able to see improvements over time in those thermogram images. And it's supplement, nutrition, detox pathways, things like that. So we're able to see improvement over time. And it was nice. It was simple imaging. I've seen very, very complex readouts and other stuff, but like keeping it simple and being able to follow, like, okay, now I've made improvements. I can feel good about that. And I know what my breasts feel like here now at optimum. I can maybe do screening every few years and really can give you that liberty once there's a solution. But again, there's a lot of controversy with thermography and imaging, and same with mammogram and imaging.
yeah, it seems like you're two camps, like either one or the other. And I think it's much more nuanced than that. And it
Yeah.
depends on case by case. But I never thought of the woman who, yeah, who's had the breast cancer. She's now in remission. She's got all of her, everything sorted out, but yet she still needs to screen. So would you send her to the mammogram again, which is just more localized radiation, or you just offset it? Or would you send her faster to get an ultrasound thermogram and instead of a mammogram?
So for her, want to MRI image the other breast first to get a baseline. But
Mm.
again, I will leave that to the experts in the breast cancer realm. But I know seeing clients after having had breast cancer, that's going to want to make sure that they're following up, but also that we're being very proactive and preventive. And as a functional doctor, understanding what caused the breast cancer to begin with and addressing those issues. So it gets really complex and nuanced, especially in clients with recent diagnosis of breast cancer and and therapeutic care.
Yeah, it's so complex. We've already spoken so much, and I have another question about the. I said we were going to talk about breast cancer and HRT, but we have no more time because I think that merits a good hour just for that, and I think we'll have to save it for next time if that's okay with you.
Yeah, absolutely. I will say, just to tease for next time, is a client recently who came to see me in Dallas, and she had been diagnosed with a breast mass, and then she was trying to avoid having surgery. And so a part of that, like 6 months after she came to see me, and I was like, well, we're going to optimize you for surgery, but you have to have surgery. And she ended up with a stage 2 cancer. We worked to optimize her health so she would recover well. And the issue with her is certainly pre-diabetes, not diabetes, but pre-diabetes, like a hemoglobin A1C of 5.6, and some insulin resistance going on, as well as impaired liver detoxification. So before I can even consider the hormonal discussion with her, and she's still menstruating, she was until the tamoxifen therapy. So we want to optimize her detoxification pathways before I can even consider any other modalities. So supporting her adrenals, supporting her immune system. And then what do I feel about hormonal therapy? It's like your cancer diagnosis doesn't necessarily preclude you from that if everything else is optimized, but we can't even go there until we optimize the other aspects of your health.
Yes, it makes perfect sense too. I love that. I love it. It's just never one magic bullet. It's always a combination and a holistic approach, which you're so good at. And that's why I love you so much. And you're
Thank
just
you.
so sensible. I really appreciate everything you've shared with us. And I wanted to mention that you meant the menopause program that you had. Why am I not in this? What was it called again? Because I want to
Magic
share that.
menopause.
What?
Magic menopause. Yeah, magic menopause. Let's bring
Magic.
magic into menopause. Yeah. It's a beautiful transformation. And for whether you're before, during, or after, we've had clients in their 30s through 70s join Magic Menopause. And I love the community that we create. We have an amazing community. It's an 8-week program that's supported with weekly calls with me. Right now, there's a waiting list for our next launch, which is in the end of March, beginning of April. We'll go through it and really delve deep into optimizing our physiology, understanding our bodies and the hormones, and testing and
Everything we
of
talked
course,
about, but
vaginal, everything
deeper.
we talked about. Yeah, absolutely.
And more. So I'm going to have a link to that in the show notes so that people can go find that program. And then you mentioned, we started talking about DHEA and all that. And we did talk about this in the first episode, but I just want to remind people that you have such a great product called Jolva. And I get good feedback from it. I have to say, over the years, it's not the first time I heard it when I recorded with you. I've heard about this Jolva way before I met you. I was like, what is this Jolva? So I think it's a fabulous option for people for their vaginal health. If you're looking for vaginal DHEA, and you also, which I didn't, this was something new because the podcast right now is dropping in March, but in February you had a special offer with the Jolva and a progesterone cream, which I wasn't familiar with that you had. And that's
Yeah,
your progesterone, or this progesterone with some other things?
it's It's pure progesterone and pregnenolone with
Mm.
tripeptide. Tripeptide again for the skin. Again, if you're going to use something on your, for me, if I'm going to use something and it has a cosmetic benefit, I'm more likely to use it, right?
Yeah.
And so it has the benefits of the balancing hormones. And we've so much testimonials on it. I've refined the product over the years, so it's a really beautifully well-absorbed product. It's progesterone, pregnenolone, and tripeptide with some essential oils, and it smells good, feels good, great for the all the benefits of the hormones, but also the skin benefits, reduces age spots, helps with fine lines and wrinkles, all that good stuff too. So you get that added benefit. And vulva, remember, vulva vaginal area. Do not forget the vulva. So critical to use that. And that's kind of foundational for perimenopause and beyond. These two products work really, really well together in optimizing our hormone balance and our body's physiology as well as function. So
Mm. The progesterone, though, is that for the arms or is that vaginal or anywhere you want, face?
So it's clean product, no parabens, no fragrance, nothing like that. So it's very clean. You can use it anywhere on your body. So I typically say for cosmetic benefit, forehead, face, neck, décolletage area, and rotate it periodically. Use it also on the vulvar area, can also use in the vaginal area. And this product I've had for over a decade now. It works really, really well. So this is where you can alternate where you use it, but you want to use progesterone on thin skin. So like you wouldn't put it on your buttocks because it can store in those areas and you're not going to get the systemic good absorption. You want to use it typically on thin skin where you see veins. So
Mhm.
vulvovaginal area, lower abdomen, behind the knees, chest, inner, you can use it on your inner arms, shoulders, if you have frozen shoulders, can use it there.
Mhm.
And but rotate. So a friend of mine says you do the hormone cream Macarena, like don't keep using on the same spot every time. Although I found because face, neck, and décolletage, I typically do that on a daily basis, on a regular basis.
Oh, and if anybody's watching on YouTube, they can see how fabulous your skin is.
Thank
And you can attest to that. Is that replaceable if somebody wants to increase their systemic levels of progesterone? Is it enough?
It typically is enough. It's complementary. If we are using, and it's typically one pump, which is 20 milligrams of progesterone and 10 milligrams of pregnenolone, it's typically enough.
Hmm.
And if we need to, also for sleep, then we would prescribe 100 milligrams or 200 milligrams of bioidentical progesterone to add to that pathway for sleep additionally. So it doesn't, you want to look at it in the context of overall, is it enough for my body? How's my body doing? Am I producing them at balance? Is it an add-on to what I'm already doing? And so those are the two considerations. So early on, especially in perimenopause, it's often enough. And well beyond menopause, like I have a client who wasn't on any hormone therapy but was struggling with sleep, and so I put her on the balance cream, and I recommend virtual. I hadn't seen her in person, so can safely start with the balance cream, and it just helped her get significant life at night sleep. And what she said is, I feel like a cloud has lifted. I have my brain back. And so more and more, especially early on in my practice, when I started using progesterone, especially in women who had had a hysterectomy, it's a safe way to get it, especially if you weren't able to. But the topical benefit is that patients would come back in over and over again. I feel like a cloud has lifted. I have my memory back. I'm seeing in Technicolor again. The world is bright and beautiful, where I was just like, struggling through a fog. And so that's where that initially drove me to dig into the brain and progesterone, brain and pregnenolone research, which is substantial, and there's substantial benefits to that.
I love it. Okay. Everyone, please go check this out. I gotta get my hands on some of this too. When I saw this, I'm like, why don't I have this? I'm in Europe, so I know it's difficult for me to get
Oh
in
my
Europe,
God,
but
we have a distributor in the UK. We'll have them send you some stuff right away. We have Telemira.
oh, you were in the UK now, but can you get, because I've recommended Jolva to their patient, to my client, well, clients, my community, and some of them say they can only get a little sample pack. Can they now get the full Jolva?
From the UK?
Yeah, in the
Yeah.
UK.
Yeah, should
Really?
be able to get everything. I may double check.
Yeah.
Yeah, no, but as far as I know, they are carrying our full line of products.
Oh,
So,
okay. All right. Oh, well,
yeah,
then I can get some more of this. So I
Yeah.
really trust you. I think everyone should go
Thank
check
you.
out your shop. You created these things as a doctor and helping your patients, and there's nothing but the best in here. So I appreciate you so much. Thank you for everything. I'll have the contact, how to find you, drAnnaCabeca.com. I've got your Facebook, your Instagram, you're everywhere. And I absolutely love you. The books that you have, I'll have these all included in the show notes. You might have maca. I get also great feedback on this. So that's another, you mentioned maca as one of your hacks for radiation when you fly, but it
Mhm.
does so much more than that. But we talked a little bit about that in the last episode. So you're going to have to go and listen to that because I have to let you go.
Well, thank you. Thanks for having me. I love talking to you. And yeah, and I appreciate this opportunity and also all that you're doing, raising awareness. So anytime, Zora. Thank
Thank
you,
you.
everyone.
Thank you so much. And thank you everyone who's listening and you made it to the end, and we will see you next time. Take care.